I have no disclosures. Our clinical question is, what does the evidence suggest for the best treatment strategies for tendon injuries around the ankle? There are a lot of them, so I will hustle through the anatomy here. I only briefly touch on the EDL and EHL, as those are seldomly injured. Same with the flexor digitorum longus. The FHL can be injured in dancers, and that's sort of the main thing to take away from the FHL. Posterior medial ankle pain in a dancer, you have to think of an FHL injury. So as we briefly discussed, we're looking laterally here. We have our peroneal tendons, brevis and longus, EDL and EHL, seldomly injured. We have our Achilles tendon. Medially, we have our Tom, Dick, and Harry, right? PTT, FDL, nervous. We have our neurovascular bundle. Then we have FHL back here. Don't forget about the tibialis anterior. An axial view of the ankle can be interesting. The black dots are our tendons here. So tibialis anterior is anteriorly there, EHL and EDL. Coming around laterally, we have peroneus brevis and longus. The brevis is closer to the fibula. It's flatter, and that will be important when we get into discussing injuries thereabouts. Achilles tendon, and then if we come from medial going posteriorly, Tom, Dick, and Harry, here is our neurovascular bundle. So we have our PTT, our FDL, the posterior tibial nerve and artery, and then our FHL. Let's start with the Achilles tendon. So we can have an Achilles tendonitis, or we can have Achilles tendon ruptures. When you have a tendonitis, it can be insertional or non-insertional. What do we mean by that? So insertional, you may see a patient like this in your office, maybe a runner, maybe just a normal, ordinary citizen who starts developing heel pain. And on the back of the heel, you'll see what we call a pump bump right here. An obvious bump, it's an easy diagnosis, that is insertional Achilles tendonitis. Compared to non-insertional, which is tendonitis in the mid-substance, they're more tender right in the middle of the Achilles, it may be swollen there as well. The distinction is not always that important because the treatment is very similar. When we have, overall we call these tendonitis, but pathologically, as this becomes more chronic, it's a tendinosis. The treatment is the same for both. If it is severe, the patient's limping, this has been going on for a while, we immobilize them in a boot. The mainstay of treatment is therapy, home stretching programs, or dedicated PT. They need eccentric exercises. That has been proven time and again in the literature to be the best form of therapy. NSAIDs, both oral and topical. There's several modalities we can use. I do want to point out that shockwave therapy has been proven in several studies to have some benefit in some of the tendinopathies, including Achilles tendonitis. That sounds a little crazy, maybe the first time you've heard of it, but extracorporeal shockwave therapy does have some benefit. If all else fails, we can debride the tendon to help remove the tendinotic tissue. When you do that, you have to be prepared to supplement that. If you've taken away enough tissue, you may need to supplement it. In this case, we use the FHL to support the Achilles tendon. Many people ask about PRP, an ongoing point of research, but here we will just say that the majority of studies do not support the use of PRP. It was the craze maybe 5 or 10 years ago, but many good studies have started to come out that are showing little, if any, benefit in the majority of the time. However, level 4 studies, which aren't well controlled and aren't well put together very well, do show some benefit. Oftentimes those are supported by the industry. There's one good level 1 study out there that compared PRP to a placebo saline injection and showed no difference for Achilles tendonitis. It's very expensive, it's not covered by insurance. However, I will add that some of the studies may be showing some benefit with lateral epicondylitis and patellar tendinosis. So there is some promise for the future, but what we're still figuring out is who best is suited for this, when do you give this, how do you give it, how frequently do you give it, what's the pH, what's the concentration, what is the patient's platelet count, how does that matter? There are a lot of factors that have not been figured out yet. Let's get into Achilles tendon rupture. You can have an Achilles tendon mid-substance rupture, that's the one we most commonly think about, but I do want to make you aware of a calcaneal avulsion. This is more common in the elderly. You see this down here in this picture. This is a bad picture to have. That's a volst. It's turned around about 180 degrees. That will tent the skin and put the skin at risk for erosion. That's a relative surgical emergency. That has to go to the operating room that day. You see this in the elderly. So someone 60 or 70 years old, even older, has what you think is an Achilles rupture. You really need an x-ray on that patient to ensure that you don't need to reduce this and fix it with screws that day. More commonly, it's the mid-substance rupture that we are pretty familiar with. Recreational athletes, weekend warriors in their 30s and 40s, much more common in men. As most of you know, it's typically a non-contact injury. They hear or feel a pop in the back of the leg. I think it's important to note that many of these players can walk off the field. Brandon Oliver, however, was not able to. He's the running back for the San Diego Chargers right here, catches the ball, and down he goes. He knew something happened. He can't walk off the field. It's his right leg there. All right. If we look a little more closely, is that going? The diagnosis is not really in question there. Okay, but how does it look? If you haven't seen one, the ankle on the left is the injured ankle, patient in the prone position. It's more swollen. You may start to see some ecchymosis. Importantly, it assumes a more dorsiflexed position. It doesn't have the normal 10 to 15 degrees of assumed plantar flexion that we normally have. You don't see the outlines of the Achilles there. An MRI can be ordered, but should not be necessary. Best way to diagnose this, most would say, is the Thompson Test. Patient's prone. This is the normal ankle. Squeeze the calf, and the foot should plantar flex towards the ceiling. The affected side, squeeze the calf. You get very little motion, if any. If anything, it's actually dorsiflexing. That's a Thompson test. So do we need an MRI? Patients often want an MRI to prove that they have an Achilles rupture, but a decent level 2 study from a few years back demonstrated that physical findings of an abnormal Thompson test, a palpable tendon gap, and decreased resting tension of the ankle, meaning assuming that more dorsiflex position, is 100% sensitive, and more sensitive than an MRI. An MRI may show partial tear, may raise some questions. It's obviously costly. It's costly in money, but it's also costly in time. In this study, there was a delay in diagnosis and treatment of around 7 days. That doesn't matter that much, but if you start getting up towards 2 or 3 weeks, you may have a little bit harder time repairing that Achilles. So MRI is not necessary unless for some reason the diagnosis is in question. What are our treatment options? Non-operative and operative treatment are both good options. One big takeaway I want to make sure everyone is aware of: some people are not aware that you can treat these non-operatively. But how do you do that? You can treat them in a cast, you can treat them in a boot, you can weight bear them early or late, you can immobilize them, or you can start with early range of motion, whether or not you treat it operatively or non-operatively. There's different ways to fix it. If you do fix it with surgery, open procedures, percutaneous procedures, there's a lot of literature on that. But really what I want you to consider are the healing rate options for operative versus non-operative, the re-rupture rate, when do people get back to their work, their sport, and what are the complications. This is what we're trying to avoid. This is a nightmare for the patient, for the surgeon. This does happen with surgery, and it's not an easy fix. So historically, non-operative treatment consisted of a short leg cast and non-weight bearing for up to 3 months. There's a high rate of re-rupture, and that's part of the reason we fix them, up to 21%. Operative treatment typically used to get a short leg cast as well, and they would be non-weight bearing for up to 2 months. The re-rupture rate was significantly diminished, but there's a definite risk of wound complications, infection, wound breakdown. It's not that high, 0 to 5%, but if you're one of those folks, it is very high. This all started to change somewhere after the turn of the century. Twaddle performed this level 1 randomized controlled trial comparing operative and non-operative treatment options. They started early range of motion, and that was one of the paradigm shifts. After 2 weeks in a splint, they started early, gentle range of motion. Patients were non-weight bearing for 6 weeks. It was a relatively small study, but they had 1 year follow-up, and they showed no difference in the re-rupture rate. In addition, no difference in functional scores. This was a surprise to many in the community. And then Willits, a couple years later, performed an elegant study in JBJS, randomized controlled trial, 2-year follow-up, higher number of patients, and they compared operative and non-operative. Both groups were allowed to weight bear early, so that was the other change. Early range of motion, early weight bearing. They also mentioned that they allowed early range of motion, although unfortunately they never actually explained when they started that. Their re-rupture rate was just under 5%, pretty good, a lot better than the 21% in the literature. And they had no difference between the two groups. In addition, no clinically important difference in terms of function. So again, they mentioned how non-operative treatment with early range of motion, early weight bearing, is a reasonable option. So that's where we were going, and up until this study, which showed perhaps non-operative treatment is not the best way to go. This study compared operative and non-operative treatment. However, this to me is one of the problems with our literature. This is a randomized controlled trial. This is a level 1 trial, 1 year follow-up, yet it is not comparing apples to apples. So I don't think you can get good conclusions from this study in that the non-operative treatment group was in a boot for 8 weeks, and they did not start ranging their ankle for the first 8 weeks. They had a 10% re-rupture rate, so a little bit less, or perhaps even half of what is quoted in the literature, but still probably too high for us to be comfortable with that. That's compared to the operative group, which had a 0% re-rupture rate. So then you could assume that maybe we should fix all of these. But the post-operative protocol was not the same, so I don't think this was a good study, despite being a level 1 study. There are a lot of studies out there. Evidence-based medicine was not necessarily something that we focused on until perhaps 10 years ago. The Achilles, for whatever reason, Achilles Ruptures has a lot of good level 1 studies out there, a couple of not so good level 1 and 2 studies out there. But in summary, one can safely conclude that the Achilles can be treated non-operatively when it ruptures. Operative treatment still carries an infection risk. Re-rupture risk is diminished if you start early range of motion and early weight bearing. If you operate on these patients, they actually do better also if you start early weight bearing and early range of motion. So what we should not do, whether we treat it operatively or non-operatively, is we should not put them in a cast and keep them non-weight bearing for 12 weeks. I think we've learned that. It is important to note also in the literature that regardless of the treatment, a large number of these athletes never return to their prior level of play. It is still a bad injury. What do we do in high-level athletes? It's a matter of debate, but most pro athletes are going to have this tendon repaired, probably to help decrease any re-rupture rate, to get them back a little bit earlier, and to potentially increase their push-off strength, which may be a little bit lacking in the non-operative group. If it's mine, treat it non-operatively. All right, moving along. Peroneal tendons. Peroneal tendonitis is something we commonly see. A little bit less common are more traumatic injuries to the tendons. The peroneus brevis can have a split tear, and you can also dislocate these tendons. Here we see in this top photo a swollen posterior lateral ankle. This patient's been complaining of ankle pain. Perhaps they are a runner. There was no injury. They were diagnosed. Sometimes it can be diagnosed by way of an MRI. This is the axial view showing the white signal, which is inflammation around the peroneus longus. That flat structure just behind that is your peroneus brevis. The treatment for peroneal tendonitis is similar to many of the other tendinous problems around the ankle. We rest it, we give it NSAIDs. A cam walker boot is always helpful. These patients can get a lateral heel wedge to unload the posterolateral part of the ankle. In recalcitrant cases, we will debride these tendons. But when you debride these tendons, you have to be prepared to see a split peroneus brevis. The brevis can tear acutely, or perhaps more commonly attritionally, as it erodes over the fibula. You might find this on an MRI, but what you see when you explore them surgically, here is the ankle. This is your peroneus brevis. This hole in the middle is the split tear. It has been rubbing over the edge of the fibula, and in this schematic, you can see how that fibula acts like a knife cutting right through the middle of that peroneus brevis. You need to debride that, you need to sew that back together, and that can help a lot of their symptoms. But they may be dislocating those tendons as well. Something we sometimes see, rarely, but you can see someone sprains their ankle, they get an x-ray in the emergency room, maybe normal, maybe read as normal, or perhaps there's a small fibula fracture. What this can be is an avulsion of the superior peroneal retinaculum. And what that means is now the tendons, longus and brevis, are at risk of being unstable. They can dislocate out of the fibular groove. If you see this, you sort of want to get them in and evaluate them earlier rather than later, because that may be an indication for early surgery. Patients who are dislocating their tendons, such as this patient, the tendon has dislocated from behind the fibula anteriorly. They may come in complaining of popping or catching on the posterolateral ankle. Usually there's some sort of history of prior trauma or sprain. You can elicit this. It's pretty rare, but you can elicit the dislocating tendons by resisted dorsiflexion and eversion, or having the patient circumduct their ankle, and they may be able to do this themselves. An important thing to consider when you are starting to talk about surgery is what's called the fibular groove concavity. The back of the fibula is concave, and that's where these tendons sit. Some people, however, have a more flat or even convex groove, and then the tendons don't like to sit in there as well, and they can dislocate more easily. So if you are going to go in there to stabilize these tendons, you repair the retinaculum, but what we often want to do is deepen that groove so there's more of a little valley for those tendons to sit in. There's a level 4 study, not a great study, but comparing retinacular repair versus retinacular repair plus groove deepening. And the group with groove deepening did better. They got back to their sport more consistently. So moving along, tibialis anterior ruptures. This is a rare injury. This is something you might see in the elderly. Often a patient in a nursing home comes to the office. She has a dropped foot. She can't dorsiflex her foot. Some people may be thinking neurological injury, maybe thinking stroke. But what really has happened is that she had an attritional tear of her tibialis anterior. That can happen with a minor trauma. Sometimes you never know exactly when it happened. But the patient's not dorsiflexing their foot, and it becomes a problem. They can trip over that foot, and now they broke their hip. So if you can recognize this, you can treat it with sometimes just the right ankle brace. Elderly patient may not want to undergo surgery for this. But some studies have shown, including the systematic review, that repair probably does better than just the brace alone, although the overall literature quality is poor. But a tibialis anterior rupture can occur most commonly in the elderly. Finally, posterior tibial tendon. This is a topic that it could be reserved for its own conference. There's a lot of information to go over with the PTT, but in summary, their PTT dysfunction is sometimes referred to as acquired flatfoot deformity. You see it in adults. It starts with medial ankle pain in what's called the watershed area of that tendon. It is vulnerable to tendonitis and then rupture. It eventually can tear attritionally over time, and it can lead to a flatfoot deformity, as I'll show you in a second. Not to be confused with the flexible flat foot, which is often a complaint in children and teenagers. If when they go up on their tiptoes, their arch restores itself, that's normal. And as they get older, some of the flexible flat feet problems go away. Accessory navicular problems are another issue in teenagers and adults. But this is what it looks like. Flat feet, this is an adult, their arch, there is no arch. If you look from behind, they have a hindfoot valgus. There's something called a too many toes sign. So on the left, you're seeing way too many toes and you should be from behind. The right side has a little bit of hindfoot valgus. You see 3 or 4 toes, but on the left side here, you see all of their toes, hindfoot valgus, no arch. That's a PTT problem. Walk around town, look on the subway, you'll see people shuffling down the feet with this problem. They need an arch support, they may need a boot, they may need surgery. We grade this in stages, and those stages help direct what the management should be. Most commonly, we see stage 1, which is tendonitis, pain, soreness over the medial ankle. They have a flat foot, but it is considered flexible. They're able to do a single heel rise. That's an important distinction, because as you get to stage 2, their foot is still flexible. It's not rigidly stuck in that flat position, but they can't do a single heel rise. That tendon is essentially ruptured. As you move along the stages, there's more fixed deformity, there's more ankle involvement, more complex surgeries. But what do we do? Like many of the tendon problems we see, start with a boot, start with some rest, NSAIDs. In this case, we will move from the boot to what's called an Arizona brace. That's an AFO, ankle foot orthosis. That's custom molded to the patient's ankle. That may be something they have to wear long-term or even permanently. Sometimes you can switch them to a UCBL, that's University of California at Berkeley Labs, which is a molded arch support. On occasion, you have to do a tenosynovectomy, so once again, you go in and you debride the tendon to help their pain. As you move further along down the stages, there's more involved surgeries where you're transferring tendons, doing bony osteotomies, fusing the hind foot, big surgeries. But this is the treatment. That's the boot on the left. In the center, that is your Arizona brace. And on the bottom right is the UCBL, which is a relatively small orthotic they can stick in their sneaker, and it gives a fair share of patients good relief. There is some evidence on how to treat this problem out there, but it is a very involved topic. I thought it was beyond the scope of this lecture to get into that any further. But in summary, all tendons around the ankle can suffer from acute, chronic, or attritional injuries. Typical treatments are the Rice method, therapy, eccentric stretches. A boot is often a good way to start, NSAIDs and PT. Recalcitrant cases may need surgical debridement and or tendon transfer. I hope everyone walks away knowing that Achilles rupture certainly can be treated non-operatively, but operative or non-operative, this should include early range of motion and early weight bearing. Evidence does support extracorporeal shockwave therapy for at least a second line of treatment for some of the tendinopathies, certainly Achilles tendinitis. Thank you very much.